Hello, everyone, and welcome to the Down Syndrome Center podcast. I'm your host, Dr. Kishore Velody, and today's podcast is really important. It's one that's actually pretty much hot off the presses as we think about things that are talked about quite a bit within the circles that I work in with folks who take care of children and adults with Down syndrome. This topic of regression is one that comes up quite a bit. Now, we did a podcast back in October of 2021 that you can go and listen to. I think it was number 116 when I just looked at it. And it'll give you a little bit more information on this topic as well. But a lot has changed in the last year and a half, 2 years. And so I wanted to see if we could bring in an expert to talk about this topic with us again. And so Dr. Jon Santoro is with us today, and we are so glad to have you here with us. Jon, thank you for joining us.
Thank you, Dr. Velody, for having me.
You know, when we last discussed this topic, it was with another Dr. Santoro, Dr. Stephanie Santoro. And I think it's interesting that there are two Dr. Santoros who are interested in this same topic, but yet not related.
Not related. I mean, we get that question all the time, but it's a great last name. But no, we're not cousins or anything like that. So
wonderful. Wonderful. Well, Jon, why don't you do this? Tell us a little bit about who you are, what you do, and what it is that got you involved in working with this population.
Yeah, so my background is I'm a pediatric neurologist by training. I did extra training to do neuroimmunology, which is the study of autoimmune diseases of the brain and spine. And along the way, I've always worked with persons with intellectual disabilities, autism spectrum disorder, but it wasn't until my residency that I had some patients that just really turned me on to Down syndrome. And we've been researching and clinically active in that area since. And along the way, it's just that reinforcement of just working with lovely patients, lovely families that has kept me involved and energized to stay active.
That's fantastic. And it's amazing to see, you know, we have over the last couple of decades now, I've been doing this type of work. It's amazing to see someone who has come in just like you, just incredibly interested and excited about a topic and really taking the leadership of that right off the bat. So we're very, very grateful to you within the community. So let's get right to the topic. I mean, this concept of Down Syndrome Regression Disorder, it's had a few names over the years. So you tell me, is this the same thing as what we were calling Unexplained Regression in Down Syndrome or Down Syndrome Disintegrative Disorder? Is this all one and the same topic?
Yeah. And so many of these terms have been thrown out over the years and used interchangeably. I mean, even from 1946, which is really the first medical literature on regression, it was called catatonic psychosis. So, I think that one of our endeavors just about a year and a half ago was to just come up with a unified name for it, make it a little bit more easily searchable, come up with criteria. But yeah, I mean, I think many of us have seen this entity. We've, identified that something is off, but I mean, even to the same extent where it was getting labeled early onset Alzheimer's disease or late onset autism, I think all of these terms were kind of describing the same, clinical phenomenon over the past couple of years.
So what are the things that are seen? Just give us a review. Like what are some of the more common features of this condition that would make them think maybe early onset Alzheimer or late onset autism? As you said, like things that people were thinking it was before. What are these symptoms that are being seen?
Yeah, so I think even before the symptoms, the time frame matters. So this is a pretty rapid deterioration in your clinical or your baseline function. So over a period of weeks to months, you go from performing your activities of daily living, communicating, happy, social, engaged, to really not doing any of that. So often the most common symptoms are catatonia or a stiffness of the muscles, bradykinesia, which is a slowing of movement, speech, processing. We often see that individuals will go from full, language capabilities or their baseline to single words, and then often will become mute. Patients will stop sleeping or invert their sleep cycle. So they're staying up all night, sleeping during the day. They're off in their own world, or sometimes we'll use the medical term encephalopathic, meaning that they'll kind of just stare out the window, and unless you're engaging with them, they won't really necessarily do anything. And then we also see a lot of new stereotypies, so hand flapping, lack of eye contact. These are things that can certainly be, diagnosed as autism if you just look at the clinical features. But we just know that autism doesn't suddenly pop up later in life. And I think that the prominent feature that gets it confused with Alzheimer's is if you're catatonic and have very slow processing, it kind of just looks like you can't remember things, even though memory actually seems to be intact with this condition.
Oh, this is, I mean, you can imagine as a family member, and of course we've experienced this here at our facility as well, where a family is watching their loved one with Down syndrome grow and develop and follow a definite trajectory that's been going oftentimes really well for their loved one. And then all of a sudden these things happen. Like, why does this happen? Like, what are some of the things that people think might be triggering this?
Yeah. And the short answer, we've identified many, many triggers to it, but we don't know if any of them are actually causative. So we often see that there's a big stressor right before. So it could be a sibling moving away for college, a death in the family, graduating high school, many different precipitants that are stressful. And, naturally, when we see a stressor and then new symptoms, we say, well, of course, this is a stress reaction, or they're not coping well with this situation. But the difference with regression versus kind of an exposure to a stressor is it just doesn't get better. And so we kind of wait it out, and eventually the symptoms are kind of looking the same or worse at 3 months, 6 months, et cetera. But these are really dramatic features. I mean, you go from, almost independent, able to do all your activities yourself, go to school, have a good time, to really just not leaving your room in some situations, or needing help even doing basic tasks like going to the bathroom. So it's really profound, and families, I've had many families say it's like having a ghost in the house, where it was, they know their child, but whoever is in the house with them right now is not them.
So are you saying then, Jon, is it a psychiatric condition, or why would a neurologist specifically interested in immunology, why would you be interested in this topic? Are there other things that people think might be contributing as well, or somehow working together with what you've just described?
Yeah, it's a great question. So I think historically, we've always thought of it as a psychiatric condition because we find these stressors. But I think, with my lens, right, I look at neuropsychiatric symptoms a little bit differently, in that if a individual without Down syndrome in with a subacute deterioration of their, clinical status or functional status, I would say that my first diagnosis would be autoimmune encephalitis. And so that requires a very broad workup. And those are autoimmune diseases of the brain that actually attack certain structures that are involved in your personality, are involved in your ability to speak and to have, executive function, or thinking out and planning activities. And so we proceeded, when I first started seeing patients with this, with a full workup, and lo and behold, we found that inflammation was present in about 20 to 30% of patients, which prompted us to start treating it. And in that minority of patients, we actually were able to reverse many of the symptoms, which was really exciting and frightening at the time when we were trying an experimental therapy, but it did work. But I think that now we're in the search for biomarkers to determine who could benefit from those treatments and who may not, who it may actually be psychiatric in.
So something like a stressor or a life event, those things can trigger an immune response. Is that what you're saying?
Yeah. And so we know that stress and the immune system are very closely related. I think that, for many of us, when you have your final exams in high school or college, everybody gets sick the next week because our stress was so high, it actually suppresses or dysregulates the immune system. But don't forget, individuals with Down syndrome are predisposed to immune dysregulation. So there's something we think about these stressors that actually kind of tips the cells that are kind of function as your Paul Revere cells, are the signaling cells, and actually activate the immune system in this minority of patients to actually start attacking the brain and other areas of the body.
And so I think you may have mentioned this earlier, but just so our listeners, I just want to make sure that we do touch on it. Like, what is the typical age range where we see this? Is it in 2-year-olds? Is it in 50-year-olds? Like, who do we see this in?
Yeah, great question. So the general time frame that we're using right now is between 10 and 30 years old. Those are made up numbers, though. So under 10, we suspect the diagnosis of autism is going to be much higher than regression. And over 30, we really have to seriously consider maybe this is actually Alzheimer's disease. But that being said, it's technically possible that regression could exist outside of those age ranges, but it's difficult to know. What we find is that in our cohort, which is now over 225 patients, females tend to present around the time of puberty, 13, 14, 15. And our males tend to present a little bit later, so 18, 19, 20, often at the time of big social transitions for our males, and obviously big puberty and endocrine changes or hormone changes for our young ladies. But they seem to be equally identified as having inflammation versus not, and are equally responsive to the different therapies, no matter what the age of onset is.
And in talking with you, and of course in our experience as well, many times the families are experiencing this, and they're bringing these concerns to their primary care doctor, or perhaps even some specialists in their area, and not really getting this diagnosis. People maybe not as familiar with it as perhaps they need to be, even within the medical field. And so, what would your thoughts be in terms of, like, a family's seeing this in their loved one, they're not getting the answers? Like, what do they do? Where do they go to get care? Do they all have to fly out to Los Angeles, or what, what do they do? How
Yeah, no, I think over the last 2 years, I've been actively trying to get people to not fly to Los Angeles
Yes.
because we don't have any special tests that we're running here. I think, the first step is to come in with an organized time frame and chronology of what is going on. Because I think that many of us, including myself, when we get into a doctor's office, we just kind of blurt everything out and it can be disorganized, whereas the doctor really wants to see what is the change in the symptom. So coming in with something, even if it's pre-written, to say, this is what little Johnny used to do, this is what he's doing right now, and this is the time frame where it happened, that is incredibly helpful. Coming in with videos to show that difference. Don't forget, sometimes, especially as a subspecialist, I may be meeting you for the first time, so I don't know what your child was doing 6 months ago, 12 months ago, 2 years ago. So videos can be really, really helpful too. And then we've posted something on the DISMIG website. If you search there for regression, it's just a PDF. It's about 3 or 4 pages, and it's designed for families to actually bring into the clinical appointment and talk about and engage with your doctor on. And so that way it's kind of serves as a discussion point, because many individuals are probably not familiar with this condition because it seems to be very rare in persons with Down syndrome. And I think that if you're not getting anywhere, what I tell everybody is kind of the same thing. If this was happening to a loved one without Down syndrome, we'd be rushing them to the hospital, we'd be admitting them through the emergency room, and we'd be proceeding with a almost urgent evaluation. So we're not doing that in persons with Down syndrome. So that can hopefully help change the frame or lens with which your pediatrician, internal medicine doctor, or even subspecialists are kind of reviewing the case.
That's great. And so for our listeners, the DISMIG, that's the Down Syndrome Medical Interest Group. That's the group that Dr. Santoro and I are and many others are a part of, where we try to share information with each other, but also with community doctors as well, as he was just discussing. So that website can be very helpful for physicians to get more information. So let's say you're seeing a child, or another physician is seeing a child, and they're suspecting this Down syndrome regression disorder. Can they just make the diagnosis and check the box and that's that? Or are there other tests or things that they need to be doing to rule out other causes?
That's an excellent question. So the diagnosis of Down syndrome regression disorder is clinical, meaning that there's no test that proves that you have it or not. There are international consensus criteria that we published 2 years ago now that are open access, meaning that doctors don't have to pay to look at it. It's freely available online for both doctors and families. What we do recommend, though, is if you meet those criteria, that you undergo an advanced diagnostic workup. And the reason for this is that Down syndrome regression disorder is still a diagnosis of exclusion, meaning that you have to look at all of the other possibilities for causes for these symptoms before we can really arrive at that diagnosis. The reason why that's so important is that even in our evaluations, we found some patients who have been having strokes, some patients who have been having rare forms of epilepsy, some patients who have had metabolic defects that we've been able to fix with, vitamin therapy, for instance. So it does happen, but I think at the same time, proceeding and going through all of those extra tests, while they may seem very burdensome, are really, really important, because we can cause harm if we're treating the wrong thing.
Yeah, and so I believe one of the studies that you've released and others have released too, looking at kind of a pathway to how to make this diagnosis that's available for doctors as well, including some of the tests that would be needed, things like MRIs and lumbar punctures and things like that, which sound scary, but are part of the workup for somebody experiencing these types of symptoms. Is that right?
Absolutely. And it doesn't have to be all done at once either.
Yeah.
So there are some individuals who get it kind of graduated, but some who are in the hospital can certainly get things done faster. But we've made it as easy as possible. So there's recommendations for all patients. And then certainly we give additional recommendations if there's a suspicion for something else. And that way it's kind of a helpful tool for the doctor that's evaluating your loved one to kind of put the pieces together and say, all right, well, we've done all this, testing that we should get for everybody, but you know what? There's this unusual feature. And here's some additional recommendations. Let's get those as well. But usually it's a pretty smooth process, even though it can be a little overwhelming at that first visit.
Okay. All right. Now let's say all of the evaluation is done, the clinical diagnosis is made. Now what? Is there possibilities for treatment? I mean, as we all know, for things like autism or Alzheimer's, while there may be things that make someone maybe feel better, in the end, there's really not a quote unquote treatment for those things. But for Down syndrome regression disorder, are there ways that this can be treated and recover some function again?
Yeah, and I would break it into kind of three categories. So the first one is treating the catatonia. So the catatonia is that slowness, the muscle stiffness, but that's actually highly treatable. And so we use things like benzodiazepines. One of the more common medicines is Ativan that we use for that. It seems like individuals with Down syndrome require higher doses than everybody else. So if the lower dose isn't working right away, give it some time. You do need to titrate it up a little bit. And we also see that things like ECT or electroconvulsive therapy, as frightening as that sounds, also is highly effective for the treatment of that particular symptom. We also have used antidepressants, again, not because we necessarily think it's depression, because it actually stimulates a lot of the language function in individuals. So it kind of reboots the brain in a way. And we've also, for some of our more agitated and aggressive patients, as a last resort, sometimes we've used antipsychotic medication. So these are ones that we would give to somebody who, let's say, has schizophrenia. Again, even though we don't think that the individual with regression has that type of diagnosis. For the individuals where we find inflammation or there's a suspicion for inflammation, we use things like immunotherapy. That can be steroids in some situations, IVIG, which is intravenous immunoglobulin. And we're actually opening up a clinical trial for that in about 3 weeks now to test the difference between lorazepam, IVIG, and a new immunotherapy called tofacitinib, which is a JAK inhibitor. So if you Google that one, JAK inhibitor, and this is a medicine that we think is more targeted to the type of inflammation that individuals with Down syndrome have.
So the study sounds like it'll be really interesting to see what might be most effective, or perhaps effective in different areas. If a family has a suspicion or a diagnosis that their child may have, or their loved one may have this condition, is this something that you're enrolling for in a study, or is this for like local families? Like, who should be seeking out this study?
Yeah, so pretty much anyone. We've made it so that it's all inclusive. So even if you've been treated before, you can still enroll in the study and you're eligible for the study. What we would require, though, is you have to come off the existing medications you're on, which is sometimes not feasible for some patients, and we understand that. But it's also good for patients who have never had any therapy. So our age restriction is, again, 8 to 30 years old. And you can be on any treatment. And what we do is we meet you clinically, and then we enroll you to the study. So that way we can make sure to tweak some of the medications. But it should be interesting. This is the first clinical trial in regression, even though we've known about the condition for 80 years. So I think as a medical community, we're very excited to have some, definitive tools in the armamentarium.
That's great. And when in your experience, when you've treated patients with the existing therapies, have you seen recovery? Have you seen the patients who were in this catatonic, not moving, not speaking, kind of, regressed into themselves almost? Have you seen them come back to where they were before?
Yeah. So I think that was really the most striking thing, is the first few patients we treated with this, we used immunotherapy because we found evidence of inflammation. And I had to lift my jaw off the floor because we had been looking at people who hadn't spoken, moved, or done anything in 2 years, who are now running down the hallway, speaking and engaging again. The 100%, back to baseline is still hard for us.
Mm-hmm.
Even with immunotherapy, IVIG is a very broad treatment, so it's not very specific, but we're getting people 80 to 90% back to where they were before. There does seem to be something about this magic 3-year window. So if we can identify the diagnosis before 3 years and start treating, the outcomes are great. After 3 years, yes, people still improve, but the degree of improvement is a little bit less. And I think that that's kind of been our challenge, at least with the immunotherapies. On the flip side, ACT seems to be almost as effective as immunotherapy, but the problem is it's really hard to wean off of it. And, it's none of these treatments are risk-free, right? With ECT, we're shocking an area of the brain. where Alzheimer's eventually will develop. And so we worry about the long-term implications of that. But I think that when we've looked at some of the symptomatic treatments, the Ativans, the antidepressant compounds, things of that nature, we're getting improvement. It's just not all the way. And I think that, 30 to 40% is a boost, but we should be trying to seek more.
Yeah. Wow. So lots of different techniques have been tried. Lots of different options have been looked at. What do you see, if there's any way to pontificate? What do you see as kind of the future? Do you feel like there's going to be a magic bullet kind of medication that's going to work for everyone? Or do you feel like we're going to be in this role of where everyone's going to have individualized type of approach?
It's a great question. So I think ultimately we're going to be in a individualized approach.
Yeah.
So right now we're in the search for biomarkers. So what we've found, and hopefully we'll publish on very shortly, is that there are some features on MRI that seem to be very predictive of subsequent response to immunotherapy. If you don't have those features, we've still seen some improvement, but not to the same degree. I'm hopeful that we'll eventually have a blood test where we can just run it and say, you know what, this is a profile that looks like regression, but we're not quite there yet. We have to also base it off of the clinical features too, right? So it's okay to start with symptomatic therapy first to treat the catatonia before you run to an immunotherapy right off the bat, or vice versa. There may be cases where if there's evidence of inflammation in the cerebrospinal fluid that we obtain on a lumbar puncture, and the MRI looks like it has these particular features that seem to be predictive of immunotherapy responsiveness, that may be a patient who's better to fast track straight to immunotherapy, but we're not really sure yet. And I think that this is the problem, is we've looked at this condition and treated it a variety of different ways, but we don't have an algorithm for that, has that one size fits all, which would make it so much easier. I think there's a lot of hope about this tofacitinib medicine, but again, I don't know if everybody who has regression has an inflammatory or an immune cause for it.
Got it. And I feel like it's important to say, as we get to the end here of the podcast too, you would consider this condition as a rare thing. This isn't something that families at home should be like, oh, when is it going to happen? Is it going to be next week? Like, this is something that you would consider rare, right?
Exactly. So, I think that with many of the neurologic diseases outside of autism spectrum disorder, these are pretty rare things in individuals with Down syndrome. But that being said, it's kind of like the TSA. It's, if you see something, say something. If you're worried about it, bring it up with your doctor, because there does seem to be a temporal relationship with the time from symptom onset to the reversibility of the symptoms as well.
Perfect. Wow. Well, thank you so much for giving us this update today, and really exciting to hear that the research continues into finding optimal treatments for this condition. Are there any other things that you wanted to make sure that our audience knew before we close the podcast, or any parting thoughts you want to make sure as we close here?
Yeah, I think that, I can't stress enough, there's a lot of testing that goes into getting this diagnosis, but it's really, really important. And I think that the more regression cases that I've seen, the less confident I am when we go into getting the testing, what I'm going to find. And there have been cases where I said, this is definitely psychiatric. And then we do the lumbar puncture, and lo and behold, there's overt inflammation, right? So I think even the most keen clinician, it's funny because, like, we like to give ourselves pats on the back and say we're Down syndrome experts, but with regression, I am constantly surprised. So if it results in a different diagnosis, that's still okay. That just means we treat it a little bit different. So I want to stress that importance, even though it may seem overwhelming with the number of tests right up front.
Yeah. Well, thank you again for being a part of the podcast, all the work you're doing, of course, too, and then for being a part of the podcast today. Thank you for joining us.
No, thank you for having me. This is a lot of fun, and hopefully we'll be making some impact on families very soon with this trial coming up.
Awesome. And to our listeners, as you know, we love getting listener questions from you. So if there are any topics that you would like us to discuss, or even more details on this particular topic, feel free to reach out to us at Down Syndrome Center at chp.edu, and we'd be glad to communicate with you that way. If you would like to join us in the work that we do here at the center, including this podcast, please go to givetochildrens.org/Down Syndrome Center. But until next time, bye-bye.